Okay, let's get started. Welcome, everyone. This is Joyce Sacco with the Housing Alliance of Pennsylvania. Thank you for joining us for today's webinar on Medicaid and supportive housing services. Before we get started, we want to provide you with logistical information. Make sure you get online while we talk so you can access the visual component of the presentations today. You should have received an email from me this morning with instructions. First, click the Ready Talk link, enter your name, email address, and click Register, and you will be given access to the meeting. The lines will be muted throughout the presentation. We will open them up at the end of the webinar and make sure all questions are addressed then. We will also be recording today's webinar, and the PowerPoint slides will be sent out after the webinar today. It's my pleasure to introduce our opening presenter, Ben Loudermilk, the Executive Housing Director at the Department of Human Services. Ben has been a longtime advocate for housing for people with low incomes and other issues, and he's been a strong supporter of the Housing Alliance and the work around the state. So it's my pleasure to introduce Ben to start us off today. Ben?
Great. Thank you so much, Joyce. I appreciate the introduction. Before we advance any slides, I just wanted to mention that some of you have been involved in this from the beginning. You know that the Department of Human Services has a 5-year housing strategy, which is our comprehensive plan to connect Pennsylvanians to affordable, integrated, supportive, and accessible housing. DHS leverages internal and external resources, and we collaborate with all levels of government, private agencies, and so forth to make housing resources available and services for accessible and for a wide range of individuals served by DHS. In a moment, I'll get into the subpopulations that we're looking at, but at this point in time, I'd kick it over to Patrick Keenan, who is the Policy Director for the Pennsylvania Health Access Network. Patrick?
Thanks, Ben. Many of you have been on presentations about the Housing as Health campaign and the housing strategies, both together and separately in different Housing Alliance of Pennsylvania venues. So thank you for participating in today's webinar. For some, this may be a review of concepts that we've already covered, and we think that this timing is really important for us to kind of go back to some of these basics, because these discussions will start to move more quickly over the next couple of months throughout the course of this year. So even if you have listened before, we hope you'll be able to kind of refresh yourself, and if this is your first time hearing some of these concepts, then we certainly welcome you into the conversation. I also want to apologize. Our slides, this is one of those technical things that, you know, through passing slides back and forth, somehow we have now got them in these in this shrunken format, so you will be able to view them much more clearly. We'll send out the unshrunken versions with today's follow-up. So the key thing that we really need to be thinking about is that housing is really a critical component to someone living a healthy life and being able to access and utilize effectively their health care. It's hard to kind of see this diagram, but I mean, as many of you have heard other groups and fans say multiple times, you know, the actual care that a doctor provides, the medications, the specialists, the tests, you know, that really accounts for only 20% of someone's health outcomes. If you look more broadly at their situation, you know, 40% is really socioeconomic factors and 10% is physical environment. And housing brings together those two categories, socioeconomic factors and physical environment. So that, you know, has 50% bearing on someone's health outcomes. So more than what can be accomplished through simply getting the best quality medical care possible. Stable housing, so that being said, stable housing is one of the critical components that people need to be able to maintain their health and health care. And when you look at high utilizers, national studies have been done as well as studies here in Pennsylvania, and all of them indicate that roughly 20% of users account for 60% of costs in the healthcare system. So we're really talking about a much smaller population than the general population that has high health needs, and if we could find interventions like housing that can support their health and healthcare, we're really going to go a long way to addressing those bigger cost issues. And part of this is because housing instability leads individuals to being less likely to adhere to treatment plans, less likely to self-manage chronic diseases, less likely to maintain consistent interactions with healthcare professionals, and more likely to seek out more costly forms of care. Think the emergency room, extended hospital stays. All of this is the academic theory. The lived reality of organizations like the Pennsylvania Health Access Network is that as soon as we were able to enroll folks in expanded Medicaid coverage, they were excited to be able to get covered. This was the first time for many of them in decades that they were able to get care, and yet it didn't necessarily change their utilization patterns. They were still showing up in the emergency room even though they could access their doctor and they could get the insulin they needed to control their diabetes, simply because when weather conditions were inclement or other situations had arisen in their situation and they didn't have stable housing, they knew that if they worsened their medical condition, that's where they could go. Which speaks broadly. We have lots of problems with emergency housing and shelters, but it also speaks to that interplay between health and healthcare, because there's a connected cost there. Advocates are certainly concerned about addressing the whole picture of that individual, and so that's why groups like FAN have turned to looking at the social determinants of health. But there's also very real cost considerations, and this also is very small, so sadly you can't read it, but that light blue portion of the pie chart below is state spending on Medicaid. It is the second largest category of state spending. And the new Wolf proposed budget is $32.3 billion. Roughly $7.4 billion of that would be spent on Medicaid. The bar graph to the right shows that in the brown, we spend most of those Medicaid dollars caring for persons with disabilities. The blue is representing elderly and seniors, and the light green is families. I know it's probably really hard to see those, but those are the top ways in which we allocate Medicaid dollars. There's a very small, and on this probably minuscule line that represents purple that talks about the newly eligible Medicaid expansion program made possible under the Affordable Care Act. This is the first year where the state is going to have to begin to pick up some of the cost, and if you look at the cost relative to the overall Medicaid budget, it's incredibly small. We're talking about $240 million this year, and we expect that to grow, according to the Independent Fiscal Office, to $680 million by 2021, when we reach 800,000 folks in expanded Medicaid and have the federal match reduced down to 10%. So that doesn't seem like a lot, but when the state is really struggling with balancing its budget, these added costs from expanded Medicaid have to be taken really seriously. Ben's going to talk about next how the housing strategy actually is really targeted at addressing all four of those categories that we just talked about in the Medicaid budget. Later on, when I start reviewing the work of the Housing as Health campaign, we've really narrowed in on that newly eligible population, because as many of us read recently in the news and online, and as we turned on our televisions, Medicaid expansion was hotly contested. at the national level. Here in Pennsylvania, our administration has taken a strong, in some ways, positively aggressive stance on the benefits that Medicaid expansion has on Pennsylvania, and it clearly has had a lot of benefits, but it comes with a cost, and I think we're really going to have to start digging into those questions as we also think about improving health outcomes, and housing is the perfect way to start to get to that. So with that in mind, I'm going to pass it back to Ben, who will talk about how the state began to, acknowledging both of these trends, formulate the statewide housing strategy.
Great. Thank you, Patrick. You do a nice job of setting the table there and making the business case for why we need a housing strategy. And those of you who have seen our presentation know that we have a lot of data that supports the need to do this, and we're working on getting even more. But at the heart of the housing strategy is the concept of three core populations that overlap with many state agencies, but DHS focuses, as do many folks who are on the call, on these three core populations. We'll be focusing primarily on number one here, individuals who live in institutions but could live in the community with housing services and supports. So sometimes we talk about expansion, growth of Medicaid, and so there are things that are required to be paid for, direct entitlement items. Housing is not one of them, yet housing is a far less expensive intervention in many cases than some of the other interventions such as nursing homes and other institutional settings. The other two groups that we're looking at are individuals and families who experience homelessness or at risk of homelessness, and finally individuals who have extremely low incomes and are rent burdened. These all sort of fit into one broad category of competition for limited housing resources. If you participate in Housing Alliance webinars, you'll often hear the number cited that may even be a little conservative these days, that we need another 272,000 affordable units to meet the need in Pennsylvania. So that means that these three core populations are in competition to some extent. And so it's critically important that not only do we assist in creating new housing options, but also that we connect people, vulnerable populations, to those housing opportunities. So just broadly, and I don't want to do a deep dive into the housing strategy, those of you who have participated in our presentation in the past will recognize this, but strategy number one is really about the expansion of those housing opportunities and creating programs that will connect people to housing. Today we're talking about strategy number two, strengthen and expand housing and housing-related services and supports. Specifically, we're looking at ways to maximize Medicaid funding for housing-related services and supports, which is goal number three under that second strategy. We're also looking at, when we dive deeper, at strategy number three, assess new and existing programs to determine future needs and measure outcomes, incredibly important. And finally, the only way this works is if we work at local, state, and federal levels. I just got done speaking with somebody from HUD before I got on this webinar. So we need to promote teamwork and communication in both state and local government to develop housing opportunities for all populations served by DHS. So that gives you the broad brush. Jonathan, in a moment, will go over what we've done with those Medicaid housing-related services and supports. Patrick, I think it's back to you, though, at this point.
It is. Thanks, Ben. And I think, the state acknowledged the same things that advocates like FAN and the Housing Alliance did, and formulated that housing strategy. At the same time, FAN and the Housing Alliance with other groups, Project Home, the Pennsylvania Health Law Project, and others, began to kind of take these same kinds of questions as the state was formulating its housing strategy, and decided that it would embark on a process of conducting a crosswalk. So part of this, the next couple of slides are really going to be are intended as background to help folks that are hearing this for a second time and hoping it sinks in, or hearing it for their first time. It's really intended to familiarize people with the terms that are being used, what we're specifically talking about, so that further discussions down the road can be a little easier or a little clearer. So as advocates, we came together and we knew that housing was something that we wanted to be able to focus on, but we didn't quite know where we wanted to go with that. We needed a map. And a crosswalk provides exactly that map. What we did is we, under the guidance from the Centers for Medicaid and Medicare Services in June 2015, guidance that promoted states to explore ways in which to use pre-tenancy and tenancy-sustaining services to help folks in Medicaid enter housing successfully with all the right stuff. Stuff is my word, not technical, but it's really about, it's not just about getting the lease signed, it's about getting furniture in there, it's about getting the ID so that you can sign the lease. It's really all of the steps and making sure that housing is desirable to the tenant, it meets their housing needs, it is environmentally safe and healthy for them. All of those key parts to getting someone into the right place. And then tenancy sustaining services, which are really about making sure that, once we've found that right place, people stay in that place. So when problems arise between the tenant and landlord, there's ways to resolve those problems amicably for both sides. There's, additional supports given to the tenant to help them understand their obligations and, continue to live successfully within the community. And, we use the word tenancy, but I think you'll hear from Jonathan later on that we're really kind of shifting towards, multiple fashions of living within the community, whether it's, tenancy, home ownership, community-based living, there's multiple venues, but, we're really talking about getting people into the right place with the right stuff and keeping people in that place, whatever that place may be. So we took that instruction from the Centers for Medicaid and Medicare Services, focusing in on those two categories, and we conducted a crosswalk which compared those definitions that CMS had offered to the state's current Medicaid plan to determine what alignments and gaps existed. This was conducted by the Corporation for Supportive Housing, CSH, and a little additional Medicaid background for folks specific to Pennsylvania about how Medicaid is administered. So there are 4 functional units under the Department of Human Services that administer portions of Medicaid. There are, of those 4, they're grouped 2 and 2. 2 which are solely state administered and the state's responsibility, and 2 which are state-county partnerships where it's the state interacting with the individual county authorities. So we have them broken out there for you. You've got the Office of Long-Term Living, OLTL, Office of Medical Assistance Programs, OMAP, the Office of Mental Health and Substance Abuse Services, OMSAS, and the Office of Developmental Programs, ODP. And you can see the populations that each of those covers, which is really relevant to, kind of conducting a crosswalk. And of course, it helps all of us understand that when, Ben's talking about a housing strategy, it sounds really neat and orderly and something that you can accomplish in, a couple of brushstrokes, but in reality, it's a really complex thing because it has to be worked into the plans of each of these individual 4 units. And there's overlap depending on the needs of particular populations. The best examples of overlap are really between OMAP and OMSAS because folks often have, both physical health needs that, could be addressed through housing as well as, a co-occurring behavioral health or mental health or substance use disorder. And so, there's obviously one part of the, part of the design questions that the state is going to have to consider is how to, make sure they're getting the right services to the right unit, to the right people for the right things. And we should also mention in this that OLTL, the Office of Long-Term Living, is going through one of the most aggressive, comprehensive, and challenging, but really skillfully led transitions from its current fee-for-service system to a managed care system and the Community Health Choices program. Many of these housing conversations have already been happening, in OLTL, and Jonathan can talk a little bit about that. But OLTL has really been having to kind of integrate housing for a long time, as it's been planning for CHC over the past 3 or 4 years, and really years and years prior to that. So I think it's helpful to understand what the state is up against, and we in our crosswalk, because we really want to target in on the expansion population, because we see the most immediate potential threat to the expansion population benefits as those costs increase and the state has decreased funds. We really need to find innovative ways of doing that. And so we focused in on OMSAS, not because we want to ignore any of the other populations like ODP or OLTL, but really because we know that OLTL with seniors and individuals with disabilities is much further along in this process. When we conducted our crosswalk, the conclusions were able to be summarized in 5 points. Pennsylvania really needs to explicitly include pre-tenancy and tenancy sustaining services in its state plan. The group that is locked out right now from receiving supportive housing services are those with a primary substance use disorder diagnosis or a non-SMI mental health issue. So right now, individuals with serious mental illness, schizophrenia, bipolar disorder, other kinds of serious mental illness can receive supportive housing services, but it's much more difficult if someone has multiple major depression episodes or has that co-occurring with a substance use disorder. We also, the last 3 points are really about making sure that whatever system that we create here in Pennsylvania, that the state spends a significant amount of time building capacity within the managed care organizations to help support the providers in forming new partnerships and new ways of integrating this, and that the state really calls on the managed care organizations to do that. But before they can ask the managed care organizations to do that, they need to build capacity. The state needs to build capacity within the MCOs themselves, and really, hone in on this being part of the whole person model of care, which the state has really been advancing in recent years. And then the last thing is that, we anticipate, and we'll talk about the savings that we anticipate to see, but any of those savings, we would really like to see reinvested in expanded supportive housing, particularly supportive housing services. So another definition kind of slide in here is about, documents. We talked about the functional units that administer Medicaid in Pennsylvania. What are the documents that control Medicaid? It's really 2 sets of documents. One is the state plan and state plan amendments. This may come as a surprise because most people think of a plan as something that can kind of be put neatly into a binder, like the housing strategy, and reviewed easily and read from cover to cover. Pennsylvania's state plan, all Medicaid state plans, don't actually exist in that way. They are hundreds and hundreds of PDFs, some from 4 decades ago, from the 1970s, that still have some bearing, or portions of them have bearing on Pennsylvania's Medicaid program. You actually need to order the entire state plan on a CD or a DVD. So just to kind of clarify that. But what happens is that, our plan is so big because frequently the state chooses to make amendments to its plan. And amendments are, they're generally very broad, but they have to be uniformity is a key component of all of this. So they're broad, but they have to apply in a uniform fashion to the Medicaid program. And state plan amendments generally define groups, benefits, provider reimbursement, and other administrative functions of the Medicaid program. The biggest state plan amendment that we've done recently is when we expanded Medicaid in a traditional Medicaid expansion under Governor Wolf. We unified the state's physical health benefit package for adults between the ages of 21 and 64. So every adult in Pennsylvania's Medicaid program has the same high-quality benefits package. So that's a great example of a state plan amendment. Waivers are much narrower in their scope, and they go much deeper than state plan amendments, deeper into the weeds per se. Really kind of honing down and kind of creating special programs. The most common things, Pennsylvania has been a managed care state since 1997. And that's done through a 1915B managed care waiver. There's a 1915C waiver, which provides for home and community-based services. The waiver programs that many persons with disabilities or seniors rely on to live in the community. And then under the Affordable Care Act, we've seen the ability of states to really innovate within their Medicaid program to find new solutions that are cost neutral, but enhance the health outcomes of their enrollees. Those are called 1115 demonstration project waivers. Some states, in many states, they're not always good waivers. They can be used in a wolf in sheep's clothing kind of thing, but the intent of 1115 waivers, other states, do really amazing things, and so waivers are just ways of creating special programs or special categories or classes that really help accomplish a certain goal. So as we're talking, as Ben and Jonathan kind of talk about where the state's going, it's kind of important to kind of be familiar with those two terms, because much of what we want to do with supportive housing services will be accomplished through those two vehicles. So we talked about cost in the beginning of this, and to kind of summarize and kind of wrap this up here, we knew that we couldn't simply have this crosswalk with these great recommendations, but we needed very concrete results that could be accomplished through providing supportive housing services. We did a business case which analyzed data from Pennsylvania's Medicaid program, and we're very thankful to being able to work with the Department of Human Services and getting and obtaining some of this data. The study looked at a small population of chronically homeless individuals with Medicaid in the top 10% of costs. You can see what the average annual cost for this population is. By providing supportive housing, it's $37,000. Providing supportive housing services through Medicaid would cost the state only an estimated $3,300 per person annually. I should mention, just because I'll do the due diligence for Jonathan, that this is an independent analysis by the Corporation for Supportive Housing Services. This is not the final state analysis, which Jonathan will kind of catch folks up on later. But we would project that by providing those supportive housing services, we would see a conservative 24% reduction in medical costs. which after providing the benefit, and accounting for those costs, the additional costs for the benefit, the state, and then also considering the portion of the state's responsibility, because Medicaid is a split partnership between the federal government and the states. The state's portion of the savings would be $147 million. There would be additional savings to the federal government as well. And, if we were able to take those dollars and reinvest them, as the recommendations, call on the state to do, then we could really, kind of expand out beyond those highest utilizers where we see a diminished return, but still a significant benefit overall to the health and welfare of folks being enrolled. In conclusion, so all of these, documents and all of this work really helped us build the Housing is Health campaign. Many of you on this webinar today are members of that campaign, or your organizations have officially signed on. There's 75 organizations that have joined the Housing is Health campaign. We have, we spent a lot of time last year really kind of digging into this issue, conducting regular calls and having regional meetings, as well as a statewide lawmaker education day in Harrisburg that really helped kind of get the message out about supportive housing services. Things have been on a bit of a pause because we've been waiting to kind of realign with the great work that Jonathan and Ben have been doing, and we've also been attempting to reconcile the new federal landscape post-November's election with the goals of this campaign. And so we think right now we're in a much better position as a campaign to start really kind of thinking more intensely about these issues. And to that end, we've created 3 working groups under the umbrella of the campaign, one for chronic physical health conditions and the housing, those with housing instability, those with mental health and substance use disorders, and seniors and individuals with disabilities. So there's 6 groups really mentioned there. We've kind of grouped them in groups of 2. With kind of similar, that might have similar or overlapping needs. We also realize that many folks say, hey, I want to be in all of them or many of them, and the reality is that all of this, each of these groups will really try to coordinate and align their work as they make recommendations to the state. On the Housing is Health campaign side, we're really going to be, as I kind of mentioned, we're pushing for supportive housing services in all 4 of the Medicaid units, but particularly focused on OMAP and OMSAS, as the other units are already kind of advancing in different stages, which is the perfect opportunity to kind of pass the slides over to Jonathan McVeigh, who's actually going to talk about how the state is advancing supportive housing services. Jonathan?
Before we go to John, this is Joyce from the Housing Alliance. There's a number of questions. I just wanted to let folks know that we're going to open up the line at the end, so everyone's questions will get answered. So thanks. John?
Thank you, Joyce. Thank you, Patrick. Again, my name is Jonathan McVeigh. I'm the Executive Housing Coordinator for the Department of Human Services. And before you see a very short timeline, basically starting in June of 2015 and bringing us all the way to the present day. Basically, the first date is the informational bulletin that was released from CMS that outlined housing services. Then in the winter of 2015 and 2016, we applied for and participated in a series of technical assistance webinars from CMS. That's the IAP technical assistance. And then over the summer and through the fall, in the summer we developed our own series of crosswalks. And at that point, as Patrick had mentioned, we were trying to align our efforts, and Health Access Network had contracted with CSH to do their own crosswalks focused on the OMSAS population that Patrick mentioned earlier.
Our crosswalks were an effort to better understand the current service environment across each of the program offices, so Office of Developmental Program, Long-Term Living, and Mental Health and Substance Abuse Services. So that was over the summer, and then into the fall we worked with the program offices to draft a set of DHS-wide unified housing-related service definitions focusing on pre-tenancy and tenancy sustaining, as Patrick described earlier. And then from basically November to the present day, we sought, received, and incorporated stakeholder feedback. Many of you may actually have been some of those stakeholders, and so just wanted to thank you again for participating in that work group in January and providing the feedback that you did. So the next slide is just a quick synopsis of some of the 3 fundamental changes we made based on the feedback we received in January. And then the next 4 slides will actually show you the final service definitions. Before I go any further, I do want to just point out that these service definitions are intended to be a unified set of definitions, a sort of framework for each program office to work within. With these finalized service definitions, they will then take them and perhaps tailor them or tweak them so that it better fits their individual populations. So mental health may have slightly different terminology in their service definitions that needs to be consistent with the rest of health choices, mental health choices. And the same thing with the ODP waivers and the OLTL waivers. So for consistency with their existing waivers and terminology, some of the terminology may be tweaked and tailored. The other thing I want to make sure is clear is that these service definitions are intended, and it'll be clear when we actually look at them, but we're not proposing to pay rent. CMS has made it very clear that rent is not an option through these services. So you'll see what they consist of. So back to the stakeholder feedback, which is the slide you have in front of you. The 3 fundamental changes we made were around skill restoration and development, home ownership, and understanding / informed choice. So the skill restoration and development is essentially, we had a lot of terminology in the original definitions back in January that really focused on developing skills. So it was as though the person never had these skills before and needed new ones. So the feedback we got was, well, how about you insert some language that includes the restoration of skills. So people are just returning to the community and they just need help refreshing those skills, whatever the skills are. The second item is home ownership. And Patrick alluded to this a little bit earlier, is that a lot of the terminology is tenancy or rental focused. And so after the January stakeholder feedback meeting, we tweaked verbiage throughout the definitions so that it now references community living generally as opposed to just tenancy. We started to use the term, we actually used the term home ownership for a little bit, but then the way that worked out, it was getting a little confusing with what that meant, as though we were going to actually help people pay for their new homes and things like that. So we're sticking with some terminology that's more broad, such as community living or community residency. The third item is understanding and informed choice. So this is a really important one that I think maybe got just overlooked on our part, and so we introduced it into the housing assessment and housing planning portion of the pre-tenancy services. And basically it's the idea that although a coordinator may be able to provide a bunch of different options for a consumer, the consumer may not really understand the impact of each option and therefore wouldn't really be making an informed decision. They're just happy to get out of wherever they might be. And so we want to make sure that there is language in the service definitions that explains that ensures that the consumer is given an informed choice. So these are the pre-tenancy and transition services definitions. So these are services that are intended to prepare an individual to move out of whatever facility or institutional level of care they may be in and back into an integrated community setting. It includes a housing assessment, which identifies a comprehensive budget, housing needs, preferences, and then also potential barriers. Then based on that housing assessment, the provider will conduct a housing plan, develop a housing plan. And this is where we included the language around providing an opportunity for an informed choice to make sure that when you develop the plan that it's based on the person's choice. The plan identifies the housing services and supports the person will need, both short and long-term goals, and ensuring to address any of the barriers that were identified in the transition, the housing assessment. It will also include a crisis section, so if there are any emergent situations that the appropriate interventions have already been identified and can easily be referenced in the plan. The next couple sections of the pre-tenancy and transition services include, again, budget planning, and really I think this is very important here, and we've heard a lot about this from different folks, about actually helping the person complete a housing search, completing housing applications, completing applications for subsidies, and of course any other entitlements that might be important to help the person transition. Services will also identify and coordinate assistance for the transition, so more tangible items like a security deposit, furnishings, first month's rent, home modifications. Those are all things, identifying community resources that will help pay for those things. Some of the waivers pay for those things that are part of what are called community transition services in the Office of Long-Term Living world, for example. And then lastly, it includes conducting or facilitating an inspection of the residence just to make sure everything's ready to go. Are the home modifications complete? Is the water and utilities turned on? Is everything ready to go for the individual? So those are the pre-tenancy services. The tenancy sustaining are just as important. These are about ensuring that the person can retain their housing and maintain their integration in the community. We want to make sure that the person is able to foster or develop independence and identifies community resources to help maintain their tenancy. It also lists services that will help the individual develop or restore skills on being a good tenant or a neighbor, and also accessing community resources. It also is part of the crisis and the housing plan is the idea that we want to make sure there are services that will help the individual manage or reduce behaviors that may jeopardize their community living. So excessive noise, problems with cleanliness, exacerbation of mental health symptoms, etc. The last set of tenancy sustaining include helping the individual manage their household, understand the terms of their lease or mortgage agreement, and of course helping them develop or restore interpersonal skills. We want them to be able to develop a relationship with their landlords and their neighbors, not just to avoid eviction or other adverse evictions actions, but also to make sure that they're having a fully integrated and high quality of life in their community. And lastly, and I think very importantly also, is making sure that the housing plan is updated and monitored regularly. So as things change or evolve for the individual, the housing plan will change as well to reflect those things. So those are the service definitions that we have arrived at as a framework for the offices to use. And each office is at a different stage, and right now they're working on what is exactly the best mechanism for them to implement these services. There's a lot of other mechanics that have to go into this effort, it's not just about these service definitions, it's also about the fiscal impact and ensuring that we have the right provider qualifications determined. All of those things have to be weighed very carefully as we push forward with these services. So at this point, I'm going to hand it over back over to Ben, and he's going to tell you a little bit about some of the other next steps and some future events.
Hey, everybody. I know that we have a number of questions, and others may be holding off until the end. So I just wanted to make mention of the fact that this webinar was to occur after the first meeting of our Housing Stakeholder Work Group. Some of you may remember it being called the Housing Advisory Committee. It's actually now been retitled the Housing Stakeholder Work Group. We scheduled it right in the middle of that massive snowstorm that came through back on the 13th of March. So we're kicking off on Monday. But this would have been a deep dive after having sort of a high-level discussion at that meeting about the housing services definitions. This would have been a little bit more of a deep dive, and it would have been an opportunity for Fan to talk to you a little bit more about mechanism. So we're doing it backwards, but I think it works fine. If you have some interest in this, we have contact information on here. And Joyce, we elected to have you be the lead there. So the Housing Stakeholder Work Group, we're working on a purpose document, but really it's something that we said we would do in our housing strategy, and it's something that I believe in. And I think everybody on the call, Jonathan and Patrick, agree that if we build a housing strategy and it evolves in isolation within the department, we're asking for trouble. So the more feedback that we get from external stakeholders who are actually doing the work and have some idea of how it could be done better, I think that's where we're heading with that housing advisory, the housing stakeholder work group. The other two things are the HAPPEN calls that some of you may participate in, homeless network, and then Patrick oversees the Housing as Health campaign. Just to reiterate, we think that housing as a social determinant of health is actually a solution to cost problems and not an additional cost. And so we need to look at mechanism and understand how this will be deployed throughout the different program offices. So some of you have posed questions that may be answered differently depending on which program office we're talking about at the Department of Human Services. So we'll get into that in a moment. I did want to make mention of and call out Joyce Sacco. Joyce and I have known each other for about 10 years. And we are really going to miss her. I wish her luck in all of her future endeavors. Trying not to get choked up, but it's been great working with Joyce. She's been a terrific partner. And as I transitioned over here a year ago into the Department of Human Services, the Housing Alliance walked with me in that journey. And we've worked very closely in trying to implement this plan along with all of the great people who work at the Department of Human Services and are focused on housing, and folks like Patrick at FAN and many, many others, some of you who are on the line. So given that, I think we're coming close to the end of the hour. Joyce, do you want to open it up for questions?
I do. I first want to say thanks, Ben. That means a lot to me. I'm going to, the first question we have is from Roy, and Roy, to unmute, do *7. I'll read the question, then if you want to follow up, again, *7. What were the supportive housing services provided through Medicaid that cost only $3,300 annually?
Sure. So that goes back to the study that the Corporation for Supportive Housing did. And so, again, I think it's really important to hone in on what Jonathan said. We're not talking about rent or rent support. We're not talking about bricks and mortar. We're not talking about utilities or all of those other things. It's really about, when you think about the services that are being paid for, you're thinking about a case manager, whether it's at a housing site or at a social service agency, or, even there's been great interest with hospitals being able to kind of bill Medicaid for these services because of the populations that they serve. So you're talking about being able to not duplicate And that's a really key concept, is that, we don't want to duplicate anything that Medicaid's already paying for, but we're going to pay an estimated additional $3,300 per year to cover those other kinds of things that we've been talking about. So the rental application, like actually being able to bill Medicaid, for completing a rental application, actually being able to bill Medicaid for helping someone obtain, the paperwork that they need to obtain, actually being able to bill Medicaid, to do that housing inspection and make sure that it complies with both the client's needs, and normal standards for safety and health. And then in the tenancy sustaining side, really kind of being that link, between the landlord and the tenant. We know that this is, both are equally important, but I would say, sometimes the tenancy sustaining intervention is the one that really is time critical, because it's, the difference between someone remaining in housing and losing that housing and having to start over again, which is obviously very intensive on the system. So it's that, paying for those interventions, that work with the, tenant to make sure that they understand their rights, the coaching that goes in with that, and kind of I know Jonathan won't like this from a service definition, perspective, but, what I called is, formalized community building that really is, making housing work. So that it's the additional amount. And again, case managers would still be billing for the other kinds of things that they're already allowed to bill for under Medicaid. Roy, does that answer that?
It certainly does. Thank you.
But Victoria had a related question. I just wanted to point to our housing strategy, page 3. So I clicked back to the housing strategy link. If you take a look at that, we do a little bit more of a holistic look. On average, cost of nursing homes, $62,750, community-based, all-inclusive, $31,341. Just gives you some idea of what we anticipate, and that may even be conservative. So Patrick was looking at a slice. We took a little bit of a deeper dive, or more of a holistic.
You are now being connected to the conference. Please stand by.
Okay.
Great. Thanks, Ben.
Sure.
We have another question from Victoria. And if people aren't seeing it, they can mute themselves at *6. Again, *6. Does this paradigm include the housing services having a separate agreement with a landlord for such things as you mentioned, or home modifications? And that's from Victoria. Victoria, if you want to unmute yourself, do *7.
Thank you.
No, housing is housing. So consumers of services and tenants in housing are protected under different rules. And many years ago, HUD actually required that we scrub any tenant-landlord lease agreement of service requirements. So it's about making the services readily available, and not for people who couldn't live in the community. We sense that we're, through study, that we're unbalanced in Pennsylvania, and therefore, especially on the Office of Long-Term Living side of the equation, a number of those individuals who are now in nursing homes could move into the community with the correct level of supports and services, and we're seeing that with the Nursing Home Transition Program. On a related matter, Roy asked a question about closures of facility beds, and while there have been some announced, most notably Norristown and Hamburg, OMSAS, ODP, respectively, those are going to be careful closures over the next 18 to 24 months, and they involve collecting stakeholder feedback and making sure people get placed into the right level of care. I think we've learned lessons from the past that dumping people into a situation where they can't be well supported is a mistake. So I think it has to be a cautious move. We also are looking at a wall of need coming towards us as baby boomers age. We know that folks are going to need a number of different opportunities. Some include aging in place. Some include the beautiful low-income housing tax credit programs that we build. Some include ECHO and granny pods. And so we need a number of different interventions because building capacity on the institutional side doesn't make a whole lot of sense. Lessons learned from our drilling for impact, the impact fees in drilling for natural gas in the northern tier. You have a great growth and need for housing, and then it slams down when the need evaporates. So it's something that we need to take a close look at and make sure that we have the right balance. Patrick, Jonathan, I don't know if you had anything you needed to add.
John here. No, I don't have anything to add. You covered it all.
Does Bill Vandeveer from the western part of the state, do you have a question, Bill, to ask? Do *7 to unmute yourself.
Hello?
Hey, Bill.
Yeah. I do have a question. I work with people in their homes who are facing physical condition issues. And so the question is on modifications of those homes to enable them to remain safely, either as disabled people or elderly people are the clients that I work with. And there is money available through waivers programs, but in my experience, it's very difficult to discover how to get that money or under what conditions you would qualify. Many clients have not heard of it or do not know how to get it. And including many case managers don't know the answers to those questions. Does anything in your program address the need to make these dollars more openly intelligible to people, or apparent how they would qualify?
Yeah, Bill, I would say that that's specifically called out in the DHS housing strategy. That's the best I can tell you on the housing strategy side, because we are still thinking about how that will be implemented. One of the ideas that's imagined is that would become much more the purview of the managed care organizations as we move into the era of community health choices. And that's primarily, we recognize there's need in all of the offices, but that's primarily where we see the need at the Department of Human Services. But more broadly speaking, Jonathan, I've lost count, but we know that there are 5 or 6 different home mod programs across the state, and we need to do a better job of coordinating and then publicizing those. So we did have that idea of the brokerage a while back. Mm-hmm. We may need to reimagine that. But I agree with everything you said. I wish I had a good answer for you, but I think at this point in time, that's where we are with it. It's in the earliest of planning stages.
And can I just expand on that with the community health choices thing, because I think that that we've been, so FAN is actively participating in the rollout discussions in southwestern Pennsylvania, the first area that's going to be affected by community health choices. And this question that Bill raises has kind of come up time and time again. And I think just for folks to have a little background in community health choices is really going to be designed to incentivize the managed care entities operating under community health choices to keep people in the community, and getting bonus payments if someone leaves an institutionalized setting and transitions successfully into the community, and then getting dinged if someone leaves the community and goes back into an institutionalized setting. And so the MCOs, there's been a fairly prolonged negotiation and contracting process, which is not quite over yet for community health choices, but they have been very aware of the need to incorporate home modifications in this, and they're going to, as they build out their networks, once they kind of get through these contracting issues, it's something that the MCOs are going to do, which will in many ways supplement the existing home modification options and programs, and Ben may know better than I, but I mean, I would seek to imagine that with the addition of community health choices, we're going to see a kind of proliferation of the ability of folks to access home modifications.
We are close to being done. I did want to, David Hunter, Housing Alliance member, had one quick question if we can end with it. One slide mentioned reinvesting realized cost savings into housing/supportive housing. Has Pennsylvania committed to do that, or is that in the works?
Yeah, Pennsylvania is already doing that. Some of you may be familiar with the Behavioral Health Managed Care Organization, the BIMCOs, and Health Choices Reinvestment over on that side of the equation. That works. It's a different model than physical health choices or community health choices, in that it's largely county-driven or a group, but it's contiguous. So it's a group of counties, and so you have one managed care organization per catchment area. And so the direct investment in housing assist those subscribers directly in that particular catchment. So what you might see, Community Health Choices, what's currently envisioned is 3 statewide managed care organizations. There may be a different model, and we're working on trying to do that now. Nobody right now is talking about the savings model that's been deployed, for 10 years over on the behavioral health side. And then there may even be opportunities as housing as a social determinant of health really has become recognized. We're also hearing from the physical health choices side of the equation, which is really the big organizations, multiple across the state. So we're still envisioning what that looks like. Savings is not really something that's coming up, but investment in housing certainly is coming up.
Thank you, Ben. And that, I think, will conclude. Thank you, everyone, for joining, and have a great weekend. Thank you.
Thank you very much.
Thank you.
Don, Ben.
Bye-bye.